So now today we are going to discuss another symptoms. This is the continuation of the series making a diagnosis, that is a clinical diagnosis, in which last time we did the analysis of a symptom, chest pain. Now we are going to discuss another symptom. The patient presents with edema. Now what is edema? Edema is actually swelling of the body. The patient comes and complains that I have swelling on the body. So you have to see what sort of this swelling is. Now, this is not the localized swelling. This is a sort of a generalized swelling. This may be non-pitting. This non-pitting edema is usually seen because of the fibrofatty tissue, which is part of the obesity, and some patients have a genetic predisposition in which they have more fibrofatty tissue on certain parts of the body, and that presents as swelling. And then we've got lymphatic obstruction, which may be the cause of this non-pitting type of swelling. Now we've got pitting swelling. Pitting swelling means when you apply pressure to the swollen area, there is a pit formed, which after removal of the pressure comes back to its original position. So non-pitting edema, the pitting edema is seen in a condition in which there is abnormal hydrostatic pressure, that is the hydrostatic pressure is high, or if there is decreased in plasma oncotic pressure. Or there is a third condition which is not very common, is seen with abnormally leaking small blood vessels. So that may be the reason for patients developing edema. So we've got pitting type of edema and we've got non-pitting type of edema. The non-pitting type of edema generally is not serious except if this is because of the lymphatics. The pitting edema always have an underlying problem which we have to sort out what is the possible reason. Now, when we go for the evaluation of the edema, we see first thing we see it is pitting or it is non-pitting. When we see pitting edema, we can grade it. Grade 1 pitting edema is that when you apply pressure, there is an immediate rebound and the pitting disappears, and pit is usually less than 2 millimeters. And then we can have grade 2 pitting edema. In grade 2 pitting edema, the rebound time is usually less than 15 seconds and the pit may be 3 to 4 millimeter deep. And then we've got grade 3 pitting edema. In grade 3 pitting edema, the rebound time is between 15 seconds and 1 minute, that is 60 seconds. And the pit is usually 5 to 6 millimeter in depth. And if the pit is more than this and the rebound is between 2 to 3 minutes, this is grade 4 pitting edema. Now we see what is the severity of the pitting edema. This helps us in following the patient when we start some treatment, and we can have an assessment that this grading has improved or not improved. So this is only a morphological description of the pitting. It does not tell us about the underlying diagnosis. It just gives us a standard against which we can follow in the follow-up of the patient that the condition is improving or it is not improving. And then we evaluate the edema, we see pitting edema. Pitting edema may be seen in abnormal hydrostatic pressure, as I mentioned. For example, patient who got right heart failure, they may have pitting edema. They have generalized fluid overload, that is called anasarca, and they have pitting edema. The patients with the left-sided heart failure, they develop pulmonary edema, which has different characteristics. Now, in this lecture, we are talking about the systemic edema. You see, venous obstruction that can present with pitting edema, and then conditions where oncotic pressure or the plasma oncotic pressure is abnormal may be seen in patients who got hypoalbuminemia. The albumin content of the blood is low. That may be seen in renal diseases, that may be seen in cirrhosis of the liver, that may be seen in malabsorption or in malnutrition. And then we got abnormal permeability. Abnormal permeability is generally seen in patients who got septic shock, but that does not produce much of edema. There is another reason, drugs. Some of the drugs can cause increase in permeability and produce edema. The drugs produce edema in different way. They cause salt and water retention, and there is fluid overload that can be the cause of edema. But some of the drugs, they can cause leaking in the blood vessels that can result in the pitting type of edema. Now, in edema evaluation, for example, in non-pitting edema, we see one of the reason is lymphatic obstruction. Now, why there is lymphatic obstruction? Lymphatic obstruction, when there is lymphatic obstruction, you have to see the lymph nodes which are draining that area, are they enlarged? If they are enlarged, there may be obstruction in the lymph nodes that is causing the prevention of the drainage of lymphatic fluid which accumulates in the portion distal to the lymph nodes, and there is development of edema. That may be because of diseases affecting lymph nodes. There may be surgery, for example, when you do radical mastectomy with lymph node clearance, the edema may develop in the upper limb. Similarly, the edema can develop in the lower limbs, or if the nodes are destroyed by radiotherapy, that can result in lymphatic edema. And then you see generalized obesity can cause non-pitting type of edema, and this is generally obvious from patient's disposition that the patient is obese. Some of the hypothyroid patient may have peritibial mixed edema. That can also be a reason for non-pitting edema. And then in edema evaluation, if we see the pitting edema, what we should look for? We should look for condition in which there is abnormal high hydrostatic pressure. For example, in generalized fluid overload states, you may find there is not only edema, there is peritoneal fluid, there may be pericardial fluid, and there may be pleural fluid. Pericardial fluid is not that common, but abdominal fluid, that is ascites and pleural effusions, are common. You can also find pericardial effusion, but that generally is seen on echo. Clinically, it may not be detectable. When the patient has abnormal hydrostatic pressure, this is usually because of the right heart failure, as already mentioned. So if the patient has dependent edema, you look for the presence of JVP. JVP is raised in right heart failure. So that gives us a clue that this edema is because of the right heart failure. So this is one clue which directly directs to the examination of the heart. And you may find that there is displaced apex beat because of the heart failure. The heart is enlarged, the apex may be displaced, and then you may have abnormal heart sounds. For example, you may hear a third heart sound or a galloping heart sound indicating heart failure. And there may be other sounds may be heard, for example, some of the murmurs which may indicate that the underlying valves are abnormal. And then you look for the lung abnormalities, because in chronic obstructive airway disease, there is right heart failure because of pulmonary hypertension. So that may give us a clue that this patient may have developed cor pulmonale, that is heart failure because of lung diseases. And then you look for the presence of DVT if the swelling is in particular localized. For example, if there is pitting edema in one leg, so look for the evidence of deep venous thrombosis. Similarly, the varicose veins, they can result in dependent edema, which sometimes in the chronic cases may become non-pitting, but generally it is pitting. So look for the presence of the evidence of deep venous thrombosis, and if there are any varicose veins. And then you see, examining further the pitting edema, when patient has abnormal hydrostatic, abnormal oncotic pressure. So that may be seen in multiple diseases. When we see the edema, which is because of the oncotic pressure, generally what we see that what is the distribution of the patient's edema. The patients usually wake up with periorbital puffiness in patients who got early renal disease. In the advanced disease, they have a generalized anasarca which may be visible everywhere, but you may find that the patient gets up in the morning and there's some facial swelling, and as the day goes, patient moves on, this swelling settles down. And the patients who are bed bound, look for the edema in the pre-sacral area, because gravity determines where the pitting edema is going to settle. In patients who are ambulant, they're moving, the edema settles in the lower legs. When the patient is bed bound, it settles in the sacral area. And then look for the features of liver cell failure. Now, what are the features of liver cell failure? In addition to the fluid overload, patient may have pulmonary edema, there may be clubbing, there may be Dupuytren's contracture, there may be spider angiomas, there may be jaundice, there may be parotid enlargement, there may be gynecomastia, there may be abdominal distension. You may find abnormal blood vessels around the abdomen called caput medusa, and similarly you may find there is testicular atrophy in males and breast atrophy in the females. So you look for the presence of underlying liver disease, and then you look for the presence of renal disease. The patient may have oliguria, patient may have anuria, there may be hematuria, patient may have frothy urine, there may be hypertension, patient may be pale, and the patients are anorexic and they may also vomit as well. So look for the presence of disease of kidney, and then look for the presence of malnutrition. Patient is generally wasted, and the history can tell us about the nutrition of the patient. Not only you will have fluid overload because of the hypoalbuminemia, you may find features of other nutrient deficiencies. For example, patient may have iron deficiency, or patient may have folic acid deficiency, or patient may have other vitamin deficiencies which may be visible in these patients. So look for the presence of micronutrient deficiency. And similarly, look for the presence of malabsorption. Malabsorption presents with diarrhea. So the patient will have chronic diarrhea, which may be malabsorption type, that is large, foul-smelling stools which are difficult to flush. So, and some of the patient may even have growth retardation. So look for the presence of malabsorption. Now, when you're evaluating edema further, pitting edema, you look for the features of abnormal vascular permeability that may be seen with certain drugs. For example, the classical drugs are calcium channel blockers. As I mentioned, multiple drugs can cause edema, for example, non-steroidal anti-inflammatory drugs, or these corticosteroids, or the pioglitazone and rosiglitazone type of drug. They cause fluid retention, while calcium channel blockers, they cause leaking of the blood vessels. So the patients can have edema because of the drugs. So whenever you examine a patient of edema, always check the prescription of the patient. Are there any drugs which can be the possible reason for edema? For example, even in some patients, insulin can cause edema. So look for the presence of drugs which can produce edema. So this is how we proceed when we see a patient who has edema, and then if needed, we can go for relevant investigations. That is determined by the clinical data which we have got after the history and examination. So this is about edema, and next time we will discuss another symptom analysis. Till then, goodbye.